Good day, everybody, and welcome to session number 14 of the 4th World Sepsis Congress, One Global Health Threat, Sepsis, Pandemics, and Antimicrobial Resistance. This session 14 is entitled Maternal Sepsis, Why It Is Still in the Top 3 for Global Incidence of Sepsis. I'm Mercedes Bonet. I work at the World Health Organization in the Lebanon section, reproductive health and research, and I will be your moderator for this session. Before starting, I just would like to introduce this session by saying that now more than ever, we should make more efforts to reduce maternal mortality. WHO just published earlier this year new maternal mortality estimates for the last 20 years 20 to 2020, showing alarming setbacks for maternal health, as maternal death has either increased in a lot of countries or stagnated in almost all of the regions. We are off of track to achieve Sustainable Development Goals for reduction of maternal mortality. And efforts to reduce maternal mortality should include, without any doubt, preventing maternal death due to infections and sepsis. Indeed, infections are the third direct cause of maternal mortality after postpartum hemorrhage and pregnancy-induced hypertension. It causes around 11% of all maternal death each year. That is over 35,000 deaths every year, most of these occurring in low and middle income countries. But this is just the tip of the iceberg. As you know very well, many more women will experience morbidity, will experience disability and long-term ill health due to infections, as you will hear today in this session. For this session, we have invited an international panel of specialists that will be speaking on different topics, from the epidemiology of maternal infections and sepsis to changes that are needed in clinical practice, and also how to strengthen health systems. All those need to fight maternal sepsis. They come from Argentina to Colombia, passing through Lebanon, Malawi, US, and the UK. We will have a panel discussion. We will start, each of them will give 3 minutes statements. We welcome questions from the audience, so please use the questions chat box that is available for you if you want to ask any question to our panelists. With that, I would like to introduce you to our first speaker today, Dr. Tita. Welcome, Alan, to this session. You will be given some initial remarks on the epidemiology-based assessment of the problem of maternal sepsis. Alan is works at the University of Alabama at Birmingham in the US. He has a background in fetal medicine, perinatal epidemiology, and global health, and has led and continues to lead collaborative multi-site obstetric perinatal clinical trials and observational studies. Please, Alan, over to you for initial statement.
Thank you very much, Dr. Bonet. It's really a pleasure to be here today, and thank you for setting that up, indicating that maternal sepsis is a top 3 cause of maternal death around the world. And it's really interesting because the proportion of maternal sepsis or leading to deaths or deaths from maternal sepsis continue to increase as deaths from hemorrhage and preeclampsia and other hypertensive disorders decrease around the world. As you all know or may know, WHO only recently in 2017 defined maternal sepsis as infection that is suspected or confirmed plus organ dysfunction, and has a number of criteria to based on blood pressure, clinical and other clinical criteria to meet this definition. Interestingly, in the WHO Global Maternal Sepsis study or GLOS study that Dr. Bonet knows so well, the rates of ratios of maternal infection per 1,000 live births were presented. Overall, in that study, 70.4 per thousand. In low-income countries, 70.6 per thousand. In lower middle-income countries, approximately the same, about 72 per thousand. But in upper middle-income countries, about 106 per thousand. And then in high-income countries, 38 or 39 per thousand. So clearly a discrepancy here in the ratios associated with maternal infection per thousand births. I think to get to the bottom of this, it's important to look at some of the differences that may occur in these settings, including things around risk factors for maternal infection and sepsis, such as cesarean delivery, which is the number one risk factor. It's associated with a 3 to 10-fold increase in the risk of infection compared to those who have a vaginal delivery. And to an extent, that may explain some of the higher numbers in the low middle income countries where some of the cesarean rates may be as high as high income countries. But also looking at other risk factors, prolonged rupture of membranes, prolonged labor, obesity and diabetes mellitus, low socioeconomic status, lack of access to prenatal care, which may lead to delays in diagnosis of infection leading to sepsis, poor nutrition, primiparity, anemia, and multiple pregnancy. Additionally, just looking at the causes of maternal sepsis, there are obstetric and non-obstetric factors, including chorioamnionitis, endometritis, wound infections that go well with the cesarean sections, and then some of the other rare things. Pyelonephritis, pneumonia, mastitis, appendicitis, or cholecystitis may be some of the things that may not be directly obstetric. So I think in getting to the bottom of this, are there differences in these causes as well as differences in the risk factors for infection due to practices, differences in our settings that could contribute to relatively low rates in high-income countries and high rates in low-income countries? So I think we can have this discussion further, but I'll pause here for others to chime in. Thank you.
Thanks, Alan, for that introduction and just strengthening that message that maternal sepsis remains a real problem for recently pregnant women, and that there are risk factors that we know could be prevented and could prevent some of these infections and sepsis. And we will be discussing more about what could be the differences on these risk factors and the differences across low, middle, and high-income countries. I would like us to now watch a video that is coming straight from Malawi, telling the story of a maternal sepsis survivor and how healthcare workers and researchers are working together in Malawi to prevent, but also to better manage maternal sepsis in their settings. Maternal sepsis is one of the major causes of maternal death worldwide, particularly in low-income countries such as Malawi. In Malawi, where we will hear from healthcare workers and a sepsis survivor, the mortality ratio remains unacceptably high at 381 per 100,000 live births.
Ndindizaga 25 za kubadwa. Unfortunately, napangidwa affected ndi maternal sepsis. Nali ndimimba wano nachitira operation. Tsiku lina nditapita kubafa. Nanguliba zona ndikutusa mazi. And sister wanga nandizo kuti maziwo akuchokera babala. Kenako anakaitana a doctor ndikubwera. Atabwera atandiona anangu ndikonzapo ndizo zona ati dikite doctor ukula akabwera. Atabwa kuzandiona a doctor ja ananduza zona yakuti kozo khauti chibereko yanga chikonongeka. Kenako anamba umandipasa ma antibiotics. Anandipasa kwa masuku angapo. Kenako tsiku lina zabwera ndikuzanduza zonena kuti mene zililimu tikuyenera kuti tipite kufilita mano tikapita kufilita akuyenera kuti akachotse chiberekero changa chifukwa kuti chimawonongeka zimene zikutanthauza zonena kuti sindizakhalaso ndi mwana chifukwa kuti pamimba imene mwana amenenso ndinali naye anamwalira zinali zinthu zopweteka kwa basa koma ndinalibe chisankho china ndinalolera kupita kufilita ndikwanandichotsa chiberekero mole mene ndikuyankhula mene sindizaberekaso tachoka kufilita kuja anakandisiya ku ICU ataona zona kuti condition yanga ikusintha ananditenga nokundipitisa ku ward nkabwera daily manesi kundisuka babala paja kuti ndikhale bwino kenako ananditulusa ndinkangoyendera mafika nasiku lona kuti ndinachira.
About maternal sepsis, it's a real situation and it's a battle that we are fighting. For us as a health worker providers, we have to ensure the issues of hand hygiene because it's very crucial for us to prevent cross infection from one patient to another. And the issues of sterilizing issues, equipments in our theaters. We also need the quality equipments when we are doing these procedures to our mothers because looking at the ground, the high numbers of aseptic patients that are the ones that are done cesarean sections. The ones that are prescribing medications to these patients, they have to follow the proper guidelines on the use of antibiotics. Because once we expose these mothers to unnecessary antibiotics, they develop resistance. So when we have this maternal sepsis, it's difficult for us to battle this infection because they will need another second line of antibiotics, which is most of the times in our facilities we don't have.
Adherence to WHO guidelines and best practice on infection prevention, better detection and management of maternal sepsis can improve outcomes for mothers and their babies.
In Malawi, the Malawi Liverpool Welcome Program is working with the WHO and the Infectious Disease Institute in Uganda to understand how best to ensure the WHO guidance to prevent maternal infection and sepsis is implemented. The active prevention and treatment of maternal sepsis program is a cluster randomized trial being implemented in 60 hospitals in Malawi and Uganda. This comprehensive program aims at supporting the healthcare workers to improve their adherence to evidence-based practice to prevent infection, related mortality and severe morbidity. This includes the first M sepsis bundle. The maternal sepsis bundle, specifically developed for low resource settings, is already tested in 17 health facilities across Malawi. This bundle is to ensure that all women suspected of sepsis rapidly get the right fluid management, antibiotics, source identification, transfer to the right care, and the monitoring they need.
There remains a huge challenge to tackle the problem of maternal sepsis. We must balance the need for rapid detection and treatment of sepsis with the needs to tackle the growing burden of antimicrobial resistance and antibiotic overuse in maternity settings. It was harrowing to hear the testimony of a woman who survived sepsis but will suffer the lifelong consequences of this. We hope our efforts to develop evidence-based guidance and help practitioners to better implement what we know works will mean in the future we can see more women benefiting from safe and positive experiences throughout and after pregnancy without maternal sepsis.
And with this, I would like to introduce you to our next speaker. Helen Cheyne is a professor of midwifery. She's based at the University of Stirling in Scotland. As a midwife and researcher, He has led multiple successful programs of research in maternal child health, including different trials and evaluations on implementation as science. In 2019, she survived sepsis and has been since advocating for better prevention and management of this condition in Scotland. Helen, please, if you could give us your initial statements on your work on how sepsis affected you.
Thank you, Mercedes, and thank you for giving me the opportunity to join you at this panel this evening. As Mercedes says, I'm a midwife, and like all midwives worldwide, I'm interested and concerned about sepsis, but that isn't really why I'm here this evening. I'm here because, as Mercedes said, 4 years ago, I was very severely ill with sepsis. I survived. You don't need me to tell you that, I guess. But as you can see, not without permanent deficit. And what you can't see is that I'm also a double amputee. But yet that still makes me one of the lucky ones. And many pregnant and postnatal women and their babies are not so lucky. And I guess that's why we're all here this evening. Within the UK, sepsis remains one of the main direct causes of maternal deaths. The number of deaths from sepsis has been slowly but steadily rising in recent years, and it sits currently as one of the top 6 causes of direct maternal deaths, and that excludes sepsis deaths more recently related to COVID. So what's the role of the midwife? Well, the word midwife, of course, means with women. And the key purpose of a midwife is to support women through pregnancy, birth, and in the crucial postnatal period when, as we know, most deaths occur. And it's the midwife's key role to recognise deviation from normal and to take appropriate action, and to do this for all women, providing the same standard of care for all women, regardless of race or socio-economic status. So in countries where midwives are working, they are the most likely healthcare professional to be present and to have the opportunity to recognise the early signs of sepsis and to take action. Midwives are, of course, also well placed to educate women and families about the signs of sepsis. And that's a very important role, but recognising sepsis in the early stages is not easy. And I am here to as a witness to that, because I am a midwife and I was a nurse before I was a midwife, but I didn't recognise that I was dying of sepsis until it was really almost too late. And in fact, it was only because a friend arrived who could see that I was extremely ill that I survived at all. And for that reason, I think the most important things we need to do are to, firstly, make sure that midwives are aware of the signs and symptoms of sepsis. They are most likely, where midwives are present, they have a unique opportunity to recognise the signs of sepsis and to be a rapid first responder. In the UK, and a good example is the UK Sepsis Trust is currently working with NHS England to incorporate their signs of sepsis in the new maternal early warning system. But in order to recognise the signs of sepsis, midwives actually have to be there. So it's really important that we aim to scale up midwifery in countries where there are few midwives or no midwives. But even in the UK, I have to say this, where we have to be vigilant to a decline in numbers of midwives and an erosion of the direct care role of midwives. I've just come back today from a conference of midwives, and I was talking to them about this panel this evening. I said, what's the most important thing that I should say? And what they said was, we need to save postnatal care. We need to ensure that midwives are able to continue to provide postnatal care, as that's where most deaths occur. So thank you, Mercedes. That's my statement.
Thanks, Helen. And I think that is striking to hear from you, like even with the knowledge that we as health providers have, how difficult it can be sometimes to identify sepsis or to identify how sick a person can be. And this is something that we will talk more about during our discussion. But let's just go through the next statements from the panelists. And our third panelist is Fernanda Escobar Vidarte. She's a gynecologist, obstetrician, and intensivist from Colombia, working in Cali. And she has extensive experience also training health providers to provide better obstetric maternal care. Maria Fernanda, over to you.
Thank you, Mercedes. And I think that we are in the same way with our partners here, because probably my intervention is very similar. We know that the effective prevention, early identification, and proper management of maternal infection before to be sepsis and with sepsis can help reduce the burden on infection as an underlying and contributing cause of morbidity and mortality. But probably for us, the problem is the education. For example, the education for early identification and standardized management of maternal sepsis is a challenge worldwide. A limitation at the beginning, for example, has been established for the diagnosis of maternal sepsis due to the multiple use of definition and diversity of recognition criteria in pregnant women. For the reason in 2018, probably we are part of this definition. We participate in this definition. The WHO formulate and propose an update of the definition of maternal sepsis to be applied worldwide. And although we have this definition, the diagnostic criteria we use have not been adapted exclusively for the obstetric population and are taken for published evidence in adults. We don't have an sepsis diagnostic system just for women, and that systems like the Sepsis 3 proposed has never included women at the moment to realize and to propose this. This situation has led to position regarding the validity of these scales, the validity from the national societies like the maternal societies around the world, because many of these positions consider that no one of the definition of sepsis think the physiological changes that occur during pregnancies, and these changes can complicate the early identification of sepsis in pregnant women. On the other hand, the importance and the why and how to use the early warning systems and the diagnostic scales like the SOPA for sepsis in the obstetric setting are still being determined at all medical and educational levels. In many places, like our countries that are low and middle income countries, it still doesn't know how to use these scales, this early warning system. And additional, there are not a unified global proposal for the sequential use of the early warning systems for the risk to identify patients with risk of sepsis, and the complementary schemes such as SOPA for the diagnostic confirmation. This generates a lot of confusion for medical teams, especially in settings where the evidence is not up to date. And finally, management schemes for adults extrapolated to pregnant women have not been widely disseminated. The concept of management with bundles and emphasize the first hour is only sometimes standardized. Even today, we have difficulties in the critical care obstetric work with the early use of vasopressors in staging septic shock, simply due to the ignorance for the usefulness and the safety in obstetric patients. Then I think that the education is our probably big challenge. Thank you.
Thanks, Maria Fernanda. And we have two additional panelists that I will introduce. Before that, I wanted to remind the audience that you can either post comments or questions using the chat box, the specific chat box for your questions, that then it will be easier for me to filter and bring them for discussion. Our last two panelists bring a health system perspective to the panel. I would like first to introduce you to Sabina Malham. She is based in Canada, works at University of Sherbrooke, and has expertise in developing and analyzing organizational innovations that aim to improve access to primary health services and also to bring changes in how health human resources are used. These include family physicians, but of course, midwives and nurses. Sabina, please.
Hello, thank you, Mercedes, for introducing me. So I am really pleased to be part of this panel. I just want to remind that, of course, Lebanon has participated in the GLOSS study, and at that time I was the field coordinator who worked in collaboration with Dr. Faisal Al-Kat as a national coordinator. So I really want to use the lenses, the systems lens approach, which means we talk about prevention, about treatment, about management, and we focus on healthcare provider, medical equipment. But as a system lens approach, I usually introduce the system approach like we see healthcare providers as in interactive, interacting within their health organization structure and within the wider environment, the external context, which means they are impacted by the political, economical forces, the health system functioning, the technology as a wider environment, as organizational context. They are also interacting and they depend on the medical, the equipments, if the enabling environment, if we foster an enabling environment. Why I made this introduction? Just to make the link with what is happening in Lebanon. In Lebanon, actually, the system, our system, as you know, there is the crisis in Lebanon. There is also the blast, the port blast, which helped to collapse the system. And actually, this healthcare provider, it's an open system theory, which means to be surviving, to be all the time surviving. So you have to be impacted by positive forces and by organization at the organization level or at the external level. So which means I want to say that our healthcare provider with medical equipment, with training them, empowering them without looking at the global lens, at the global system, they cannot survive, and even the system cannot survive. That's why later on we will develop what to do in such cases and how to approach to choose or select interventions within this systemic approach and lens to be able to prevent and to manage sepsis or maternal infections.
Many thanks, Sabina, and I'm sure that during the discussions we will be very pleased to hear from that health system lens, as you call it, and how the context also affect how health workers can respond to maternal sepsis, right? Edgardo Abalos is our last panelist for this session. He's an obstetrician, but he's head of the obstetric department at Maternidad Martín. This is in Rosario, Argentina. And I think that will also bring that different health manager perspective to this session with his role. He's also co-coordinator of the Observatory of Sexual and Reproductive Health of Argentina and has quite a lot of experience in collaborating with health authorities in implementing programs and research on how best to integrate results of research into policies. Edgardo, please go ahead.
Thank you, Mercedes, and thank you all the panelists for this brilliant session. I have a kind of challenging question to make my statement, that it was if there is a role of the health system or any change in the health system to improve results from maternal sepsis in pregnant women in Argentina and beyond, in an upper middle income country like Argentina, or even in more developed countries. And after hearing the heartbreaking story of Helen, we say, yes, absolutely, that there is a role of the healthcare system to improve results, especially for those consequences of sepsis in women and also in their babies. And if we look at all the international recommendations regarding availability of resources, specifically in GLOS study, we make an analysis of the availability of resources in more than 450 hospitals in 52 countries participating in the GLOS study. And even though as was Dr. Tita raised, the individual characteristic of women have an important role in the risk of having complication of infections. And also, Dr. Tita stressed that the development of the country also is important for this increased risk in developing consequences of infection. Even in developed countries, the availability of resources and the use of those resources and the wise use of those resources also plays a role in the prevention and early detection, as Fernanda stressed out, of infection and to avoid these catastrophic consequences. For our hospital, usually we are overwhelmed by the number of patients. Usually the infrastructure is not enough. These big, busy hospitals are always dealing with the day-to-day attention of day-to-day care of patients. And this is reflected in the availability of trained personnel dedicated exclusively to infections. So half of the hospital in our GLOS study counted with an infectious disease specialist. Nurses and doctors are usually put in the front line caring for the day-to-day care of the patients, and there is less attention on this important role of the infections committee in the hospital to train and to monitor the problem at the hospital level. Human resources training also is, even in developed countries, is a problem. We found in GLOS that even though Fernanda mentioned that there is not the perfect tool for early recognition of sepsis, even the tools we count have very, very easy and low-cost components, like measuring the patient's heart rate, that is not universally applied by practitioners even in developed countries. So training of human resources for early recognition and to avoid and to prevent infection is an issue, and is a pending issue for the health system to respond to these needs for women. And lastly, in our developing countries, we have an epidemic of cesarean section. And some of our countries have resolved the wash resources. They come with water, they come with sanitation, they come with antibiotics. And usually we translate the guidelines, especially for in BC hospital for early discharge, coming from developed countries, and then we send women to their households where they lack the basic wash resources to care of surgery. So in countries in which the cesarean section rates is rapidly increasing, the hospital stays is decreasing, and the women are sent to their homes where the wash infrastructure is not assured. So there is still a big role for the health system to see the problem holistically and involve all the actors, all the stakeholders in the sectors, just to try to raise and to address this important problem. Thank you very much, Mercedes.
Thank you, Edgardo. And I think that this has been really a great introduction for the discussion we will have. We are getting some questions in the chat. If you have questions, please use the chat box to pose those questions to our panelists. I will start with our discussion, and we'll be checking the chat box to bring in the audience questions also to you. I wanted to start with a question to Helen, and I wanted to ask you, because you have this experience of having worked both in high income but also in low income countries, what do you see as like the main differences in terms of prevention, management of maternal sepsis in each of these settings? And also, because you are based in the US, where we know that maternal mortality is very high compared to other high-income countries, are there any differences within high-income countries, and what you have learned from the US situation? Thanks, Helen.
Yeah, Mercedes, thank you so much. That's a really, really great question. And just to add some additional background, I trained and worked for a while in Cameroon and continued to do work there across missions, and then also do work in Zambia and other places, although my main place of work is here in Birmingham. I think there are a number of different things that go into some of the differences, but this also highlights the concept of your question about the specificities here in the US compared to other high-income countries. This whole concept of reciprocal innovation, because here, right in the US, I think we do have places that well developed in the urban areas, but we do have the rural areas, underserved areas that also mirror some of the inequities that exist in low-income countries as well, both between high and low, but also within low-income countries as well. And I think we can learn from one setting, even in a low-income setting, and that will absolutely be applicable here in the US. In terms of differences, obviously, in general, there are more, I think, developed protocols to prevent infection in this setting, right? So prevention, GBS prophylaxis, that's mostly related to the baby, but there are other criteria that allow us to provide prophylaxis that benefits the mother in terms of preventing infection, preventing pyelonephritis in pregnancy as well. there are also protocols that allow, sepsis, the whole concept of sepsis protocols to immediately activate a whole host of actions to prevent that patient who is showing early signs of sepsis from developing more severe, sepsis that can lead to death. So, and that comes also with more frequent use of, of antibiotics. So those are some of the differences. But when you look even and compare some of the low and middle income countries with high income countries, you see that, and we've seen this in a recent large trial, where just the level of use of antibiotics is so high. Some of that may have to do with higher rates of C-section, really high rates of C-section, that contribute to high rates of infection. So the general context, as well as was already indicated, this should not occur in a vacuum. It should occur in just a general context. And there are other facilitators and barriers within the system that can ultimately lead to maternal sepsis. Yes, and those are seen within different settings in this setting, but also differences between high income and low income countries. I could go on this because this really captures what we are, just the whole discussion we're having, but we'll pause here for others. Thank you.
Many thanks, Alan. And I think that you raise very good points on how this is a condition that could affect any woman, and it's not a low or high income country problem, right? And that we know that there are certain populations that might be more at risk or exposed, and making sure that we work on addressing any risk or issues they may have is important. Antibiotic prophylaxis to prevent infections is also key. I wanted to follow up on a question for Maria Fernanda, and is around what do you see as then the main challenges health providers face when they have to identify maternal sepsis? And I will just follow up with a question that it's from someone in the audience, that you mentioned it, early warning scores. Is there a role for any other markers to detect maternal sepsis? The specific question is on early use of biomarkers to do so. Thanks, Maria.
Thank you, Mercedes. Probably I will repeat, but I think that our biggest challenge is to make the education for the proper diagnosis and management universal. To be able to put these concepts that have already been validated in evidence in a simple, understandable, and clear way from the frontline health workers. Because in the evidence, probably we have the response, and probably we can understand, but I will put this information in front of the patients, and adaptable to the context. And I want to give some example. I'm from Latin America. Most articles that have the evidence and these kind of academic events are always in English, are published in English, are conducted in English, and in our countries, less than 20% of the health personnel can communicate in English. That's the reason why we are always late, because we need this process to translate, to put in front of the health workers. The information needs to be more aggressive in a new way to try to do that. The second challenge for us is how to use the early warning system systematically, regardless of the system, because there are many. we like to use the MEOS. All of these systems are focused in the reassessment of the vital signs and being able to take very with discipline, how to interpret them and even permit rapid reference or more aggressive treatments or managements. And in the gloss, for example, we experiment that almost 25% of the patient in most critical condition of the disease didn't have complete the vital signs, at the moment of the recollect the information. And then I think it's very important to be more clear in the education that the vital signs are the most important package for our early detection. And in the same sense, and I think in the question about the labs or the other systems, for example, we can return to the measure of the capillary refill, because now in the evidence, we know that the behavior of the capillary refill is very similar to the acid lactic, but we are always thinking that the only way is, for example, use the labs. And the problem is that in our low and middle income countries, we don't have always the possibility. Probably we need to return the sample complete physical examination. And I think it's very important to think in the size of the implementations adapted at the concepts, try to put the same information to the level 1 to the level 4, to emphasize in the suspect maternal sepsis and to refer very quickly to other high complex facility, the patients to try to be more quickly or more aggressive into confirm the diagnosis and to start the management very quickly. And finally, and I think that is very important that we have more cells than human, and it's very important to try to move, to try to use technology to make education and real-time assistance more accessible, especially in areas when we don't have personal training or specialized personnel that maybe can help to our doctors, general doctors, or our nurses or our midwives that probably needs any kind of support to try to do this early management and early detection.
Many thanks, Maria Fernanda. And I think that your intervention follows very well Helen's point about that need for us to think on what are the resources health providers have available, and that the simple monitoring of vital signs could really save life. And this is something that seems to be very hard to address and improve in obstetric care. And we know very well that even if women are hospitalized in obstetric services, sometimes they don't receive the monitoring they require to do this early identification of an infection and address it in time so it doesn't become sepsis. It sounds simple, but I think that we are all really struggling to do that. We can have additional lab biomarkers that could help that process and use other technology, but just keeping in mind that we have to also sometimes stick to what we should be doing. And we know very well that monitoring of vital signs, it's one of the things is important. I will move on to a different topic, and will bring a question that is coming from the panel at the same time, and is a question for Helen, and is on what is your experience and what will be your advice to engage with healthcare, the healthcare community, the healthcare providers, so they know how to prevent, how to early detect and manage infections and maternal sepsis. Could you give us some examples? And the question from the audience is like, on how common it is that we can educate women and their families, even if they have normal pregnancy without problems, so we can help them better in the event of a future pregnancy. So beyond just sticking to addressing the problem when it happens, how this could also maybe from a healthcare worker perspective help with preventing death from maternal sepsis. And thanks, Helen.
Thank you, Mercedes. So I think I have to agree with what Maria's point was, that simple markers and simple ways of identifying early stages of sepsis has to be the front line of detection and treatment, surely. Most women that die of sepsis die in the postnatal period, and as Edgardo said, this is after they've been discharged from healthcare and they're back in the community, and you're really relying then on their family or friends to be vigilant on their behalf, because, as I've said, it is these early signs of sepsis are really, and I've thought about this from a personal point of view a number of times, and obviously aware of the signs of sepsis, but even now I think, would I have recognised those signs of sepsis in myself at an earlier stage? And I think the answer is probably still no, because most of the earlier signs of sepsis and even quite late signs of sepsis are easily confused with flu or other things. And in particular, I'm not sure who said, many of the things that women will be experiencing after childbirth could easily be confused. And I think, for what is it that makes a woman or a woman's family trigger seeking help? And I think these things are, no matter how we talk about it, just think, could it be sepsis? I think we're naturally programmed to not think of that, actually. At the same time, you don't want people to be so hyper-vigilant that they can't live their lives, and our other problem of antimicrobial resistance, as we've all spoken about. So actually, I don't think I'm answering your question at all as to how we go forward. I just think it is, well, I guess what I do think is, in order for these signs to be recognised and for women to be educated, we need to have midwives or other healthcare professionals on the ground who are able to educate the women. I don't think we can rely on women and their families to detect these early signs, especially in women that are at risk, women who've had caesarean sections. It's rather pushing the blame onto women and their families to detect it and to take the appropriate action, when really what we should be doing is providing proper postnatal health care and providing well-trained healthcare providers who have the ability to do, as Maria says, and just record the vital signs. I mean, you wouldn't necessarily need the highest level of technology. You just need a relationship with a healthcare professional. You need somebody there to record somebody's vital signs. That is the most important thing. Yes, we can educate women. Again, it's a public health issue, isn't it? And I think that's what Sabina was talking about, the systems in place. If a woman doesn't have basic hygiene in her home, how is she supposed to prevent sepsis? Now I think I'm going way beyond your question, but I think it is quite simple and quite fundamental. As you say, it sounds simple. I don't think just relying on trying to educate women and their families is the solution. I don't think that's fair. I think we need to have good postnatal healthcare in particular to give people the opportunity to have their vital signs recorded and have the opportunity to detect sepsis.
Thanks, Helen. And Maybe I can follow up with a question to Sabina, because you mentioned it, her previous intervention. And I was wondering, from what you know from Lebanon, but also from your work, and sticking with thinking about healthcare workers and what they would need, do you think that they have an enough level of awareness about maternal sepsis? Is there something that we could do at that level to improve the current situation? Thanks, Sabina.
Okay, thanks, Mercedes. I will talk in general, and because focusing on Lebanon for the time being as a country is in crisis, it's not really the best example to give. But all studies show that the level of awareness is low, and especially in low middle income countries. And the studies of awareness campaign have shown that it has helped to raise their awareness and make them more self-confident to decide. That is, also other literature review says that campaigns alone are not sufficient. We need a multimodal intervention, multimodal actions. I mean, that is why actually, if we navigate via the literature, we say that awareness is very important because we know that their level is low, and via the technology, it's really efficient, effective, and it has worked during the COVID, the pandemic, which is the worst crisis all over the world. We know that by using digital technology, by even using virtual training session, I'm talking about healthcare provider because also the public, the community we need to raise their level of awareness. So by mobile devices, even if you are in sub-Saharan Africa countries, people have their mobiles, it's essential. So also electronic media, donc we have to mobilize, to combine multiple interventions to raise their level of awareness. And what is important is that usually when we make needs assessment in general, interventions are literature offers for us what the literature says, it means the intervention via literatures. But we know very well that we cannot transfer this intervention without customizing it to the context, to the setting. What is their needs, essential needs? I mean, what works in one country doesn't work in another country. What I know in our country, in Lebanon, despite the situation, despite the crisis, despite people not being able even sometimes to afford food, but their connection with their mobiles is essential. I mean, is essential. That is, which makes us see that technology works, and it's the direct communication strategy to mobilize. This is one part of the things. But also, I would like to say that awareness is among one component of other strategies. Simplistic intervention don't work. We have, as I said, if you may allow me to make to make the link with what I have said, I am focusing, you asked me about healthcare provider, but I don't have to forget that this healthcare provider evolves and works in organizational setting structure. This organizational structure depends on the contextual external environment. So when we say, for example, we see funding for financial or funding for educating and training healthcare workers, I would say that we have to empower them, invest in them. What does it mean? Yes, we have to do training to build their capacities, but also we have to look where they are working, in which environment is it? Does it have an impact positive on them, on their motivation? What is the workload? What is the staffing levels? Do they work in crowded environment? We don't have to underestimate. I see a lot of funding, training, building capacities, but I don't see clearly like plans, or what do we do for this environment? Is it, for example, are there, for example, in some places, are there like skill mix strategies to be able, in case of having shortage of resources? We know that, for example, in Lebanon, 40% of MD, they left the country, including obstetrician, 30% of nurses and midwives. So we have always to think about the system, because all these forces, however it's positive forces or negative forces, are impacting the healthcare worker. So what do we do to empower him? Not only train him, empower him, how to adapt to the situation. For example, what do we do? What do we implement a strategy to retain and to attract staff? Let's just give you an example. With the Health Quebec system has faced major challenge about human resources, nurses dying, nurses having COVID, and actually they have the strategy of attracting nurses even from Lebanon, from my country. I mean, I know that it needs funds, but we have always to think, to be proactive. I mean, when thinking about funds to train, thinking about how to mobilize, how to have advocacy efforts, to also think about staffing levels. Let's say at the ministry, at the national level, what do we do for these human resources? Just to give a part, of course, from prevention program, control program, I can just give an example, which is, I find a good strategy of WHO in Lebanon. Actually, we have liberal midwife practicing, and I'm sorry to say, all medical doctors, and not only medical doctors, were there against practicing liberal practice midwives. Or during the pandemic, the practicing as liberal midwives has helped many women because they couldn't afford, paying the fees. So the WHO has launched the initiative of training, building their capacities on infection prevention, and following that, on-site visits assessment to make sure that they applied their knowledge and how they applied it, and also a future plan for continuous education improvement. This is like, just even for training, this is a system perspective. A system perspective, because not only we give training, we follow them, we make on-site assessment, and also we are filling the gap of human resources that existing in the health system.
Thanks, Sabina. I think that you raise a very important problem that we see everywhere. And we have examples from your country, Lebanon, but also in Latin America. But Helen could also speak about UK and Scotland, right? And we are all facing the same problems of human resources workload, and how this certainly impact how we can address maternal sepsis in health facilities and in the community. Edgardo, I wanted to follow with a question for you then, because I think that as head of a very large maternity hospital in Argentina, I'm sure that you have faced this problem. What would be your suggestions or advice? How we could try to fix this problem? Do you have any examples you would like to share, not only regarding human resources, but in general for healthcare facilities infrastructure and access to medicines, to even water, right, and sanitation?
Yes, thank you, Mercedes. If I have to resume in one word, monitoring, aggressive monitoring. So you can train, but it's, as I mentioned before, I completely agree with all my colleagues regarding the need for training and the access to the latest evidence. But if this evidence is not translated into practice, we will fail. So there, as also people mentioned in the chat in the room, you don't need expensive technologies. You can train to monitor the pulse rate, but then you have to check that the pulse rate was measured in every woman suspecting an infection. So you can train in hand washing, but you need the specialized nurse, infection disease nurse, externally watching how the staff hand wash and perform the hand wash before going to theater. Because training itself is not enough. Then you have to monitor how it was performed, it is implemented. So there are very, very cheap interventions. Just the vaginal cleansing before the cesarean section is something that is very cheap. So all the cesarean section, and it's recommended, highly recommended by WHO, they reduce the rate of post-surgical infections. So all the cesarean sections were performed, the vaginal cleansing before the surgical procedure. So you only will know that if you monitor it. So we need to be aggressive in monitoring. In our last outbreak of post-surgical infections a couple of years ago, we were the carriers. So we make the test in our skin, and the doctors and the personnel have the resistant microbes in our skin. So the intervention were directly to that. All of us, we are decolonized for germs. In the last outbreak of post-surgical infection, the germs were the vaginal flora. Is very sensitive to all antibiotics. So the problem was different. It was not the doctors carrying out the microbes, where a problem of the hygiene of the cleansing of the women. So I said, okay, 48 hours after the C-section, we are sending women to home. So to where? Are they allowed to perform all the care of their skin after the cesarean section, the care of do they have all the wash infrastructure to care about themselves, as Sabina said, and also Helen mentioned. So do we know about the living conditions of these women going home after just a very, very short time in the hospital? So the situation is not static, is evolving. So what you can have an outbreak this year that could have some reasons, and then next year you can have another outbreak and with different reasons. So my suggestion is that we need to be aggressive surveillance in the surveillance. We have to know what the problem is, try to understand it, and try to act fast as with the early detection and early recognition. Thank you.
Thanks, Edgardo. And I think that you just brought another important point, that is surveillance, right, in healthcare facilities, and also highlighting the importance of having good infection prevention and control in place. Otherwise, I don't think that you would have been able to know what was causing sometimes, right, peaks of, as you mentioned, for example, post-cesarean infections, and being able to address that seems also key to address the issue of maternal sepsis. You also touch on some risk factors, and I wanted to then come back to Alan. Could you maybe expand on what are the risk factors we know? Cesarean section have been mentioned by different panelists as one of the highest. I think that you yourself mentioned it in your introductory presentation. And again, what would be your advice then? What do we do? Some women need cesarean section, right? Sometimes, and we see in some hospitals, they have very high rates of cesarean section that might be not necessary. Yeah, I'm eager to hear from you.
Thank you, Mercedes. So you know, we've been doing some work in this area around prevention of infection, especially in C-section. So And WHO recognizes this, that antibiotic prophylaxis is key among some of the other interventions that Edgardo mentioned. But also having the appropriate indication for the C-section is crucial to prevent, a 5 to 10-fold times increase in the risk of infection compared to vaginal deliveries. So anything we can do to reduce inappropriate C-sections would be great. And we do know, we're just, again, completing a large study here where we did everything to make sure the C-section rates were reasonable, but they ended up being very, very high in some countries. So we know 75% C-section rate is not the way to go. So something, could be done there. But I wanted to, especially for those C-sections that are indicated, obviously managing the labor appropriately. So if avoiding doing the C-section at the right time, not waiting too long to do it, because that also dramatically increases the risk of infection. Interestingly, just to touch back on the comment about biomarkers, and I agree, the role for biomarker is, I don't think there is one now, but maybe there is one in the future. We did a C-section study where we, as you know, used azithromycin and added that to the usual antibiotic, and were able to reduce the C-section post-C-section infection rate by 50%. And that is standard now in the US for all post-cesarean done after labor. But we did a study there where we looked at a number in these women. We collected blood at around the time of delivery and looked at a number of biomarkers some inflammatory markers, and really then followed them until they developed different types of infections. And the model was highly predictive of who was going to get an infection for about 3 out of 5 biomarkers that we looked at, with an AUC of about 96%. It's obviously very rare to see that, but this needs to be validated. It needs to be validated, and then we need to look at things around costs associated with it. So that's potentially an area of development. We published one paper on it, of development, where you could say, well, could you, at the time they get the C-section in the hospital, do a blood test that tells you that 2 weeks later, with some high degree of precision, they are going to likely develop an infection. That might be helpful if, for the right group, if we can also find a way to make it affordable. Thank you.
Thanks, Alan. This is very good, and I think that we will all agree that regarding to cesarean section, there's also a lot to be done, and that reducing the rates of unnecessary cesarean sections will also help with addressing some of these maternal morbidities that we often see. And it's probably not only sepsis, but also, for example, postpartum hemorrhage, right? As they also have higher risk of that. I also wanted just to link something you said about monitoring labor and being able to do cesarean section at the right time, but also allow maybe women to labor longer, and sometimes that cesarean section wouldn't be needed. With something Helen mentioned at the beginning about scaling up midwifery, because I really think that it's also a way forward in terms of reducing not only maternal sepsis, but maternal morbidities in general. I was wondering, Helen, if you want to add something about that, and if you have examples from your country or other countries on how to do this.
Thank you, Mercedes. I think this is a real big challenge for us. It's here in the UK, certainly we're seeing rapidly rising cesarean section rates. And it's really quite hard to see how that's going to change anytime soon. I think I'm expecting that we're going to see increasing cesarean section rates for quite some time now. And I think that this is something really related again to what Sabina was saying about, the context and everything being interconnected and it really being a very complex situation. So for maybe the last 10 years in the UK, we have had quite a lot of attention on trying to look towards preserving normal birth, if you like, preserving a physiological approach to birth. So moving away from the rigid action lines of the Friedman curve, which dictated, how rapidly a woman's cervix would dilate, and with intervention, quite promptly, where women deviated from that, to a more, well, I want to say relaxed, but still a vigilant approach, but recognizing that cervical dilatation can be a lot longer, for some women, and less intervention. So, however, there's been more of a reversal of that, I think, in more recent years, and most recently, and that's really connected to the drive to reduce stillbirth. Now, everybody wants to reduce stillbirth, but a number of initiatives have been introduced in the UK specifically directed at reducing stillbirth, but they've had a knock-on effect, I think, of increasing the number of cesarean sections. That seems to me how that's going. So there's a kind of a knock-on effect of initiatives to try and improve maternal and infant health on one side that has potential detriment on the other, and I don't think we've yet found the balance of that. So, and we are also seeing increased cases of sepsis and maternal deaths from sepsis. I was at the conference, the International Labour and Birth Conference, and I was really interested to see the newly introduced partogram that's been developed by the WHO that aims to assist midwives in, worldwide. I think there is a move to introduce it into the UK as well, but that looks at vigilance, but allowing more opportunity for women's labour to progress more physiologically, perhaps. And that looked very promising, I think. Now, I'm less well able than you are yourself, Mercedes, to talk about that, because I think that you've been very involved in the development of that. But I think that's so that's an important opportunity there. But as I say, I do think that systems are all interconnected, and attempts to improve things in one area can have a negative knock-on effect in another. And I believe that's what we're seeing in the UK at present.
Thanks, Helen. We are approaching the end of this session, but wanted to ask a last question to Maria Fernanda. And this is also because she has been working very hard with FIGO. This is the International Federation of Gynecology and Obstetrics, around humanizing maternal care and childbirth. And I was wondering, Maria Fernanda, if you had something to add, and maybe I would expand the question to how then we humanize also the care that recently pregnant women with maternal sepsis receive, and whether that will have an impact in outcomes in your view.
Thank you, Mercedes. And I think that is very important, because in the same way of the education, we believe, like International Federation and like obstetricians, that is very important to educate in non-technical skills with our teams, because probably and I agree with all your comments. It's very important to maintain, the surveillance, to maintain, the discipline, and to try to put all this information in front of the patient with our health personnel. But it's important to maintain always in our mind that we are trading and we are doing management in some women that has family or their kids, husband or whatever. And in many places like our lower middle income countries, we are in very difficult conditions. And I understand very well what is the situation in the Lebanon and in the Africa, but inclusive in Latin America, we have little Lebanons, little Africas in the same places. Then non-technical skills that is in our health workers team is very important because we need to care our personal health before to put so many responsibilities in there. We don't in our normal formal programs in education, in medicine, for example, we are not talking about of humanization. We are not talking about regularly about the non-technical skill and about the leadership, communication, how to transfer, with empathy, the information, how to reduce, include our mortality cases with a perspective of improve our behavior, our knowledge, and our teams or our hospitals. And I think that is very important, not just the humanization with our patients, that of course is the principal outcome, is our principal goal, but we need to think in the same way in our human resource, because in many facilities there are very, very difficult conditions. It's impossible to maintain, the leadership. You don't have the minimal conditions to speak about your situation, to have the possibility to explain how is the stress in this situation. And if we don't, I'm thinking that the other part, inclusive for you, the technology, you need to maintain these non-technical skills between the teams. And in the second, I think that especially after the pandemic, we are thinking how our teams were tired, very, very tired. And we probably, and pandemic was the worst situation in a viral sepsis for our obstetric patients. Then I think that is very important to recover, the hope that at the end of the day is to recover the possibility to maintain this challenge, to maintain, the behavior of the teams in other levels. Then, and I think that for me, in this moment, after many years in critical care obstetric ICU, the most important thing is the humanization and empathy, of course, with our patient, but at the same time with our teams.
Thanks, Maria Fernanda. And I would like to introduce you to my colleague, Dr. Benedetta Allegranzi, who will be closing this session and presenting the WHO perspective on sepsis and the work that we are doing from here. She works also in Geneva, the World Health Organization, and is the lead of our Infection Prevention and Control Hub and task force. And we have been collaborating with her for many, many years now in bringing together infection prevention and control and our work on maternal sepsis. Benedetta, please, you have the floor.
Thanks a lot, Mercedes. Really many thanks to you and to colleagues, the panelists, for this really interesting session. It is very difficult, of course, for me to make some closing remarks and wrapping up, and also point out a few aspects of the work we do. The panelists gave really exceptional insights from epidemiology of maternal sepsis to gaps and improvements needed in clinical care, as well as advocacy, and many other aspects, so that no women die from sepsis during or after pregnancy. They have emphasized the urgent need for strengthening identification, management, and prevention of maternal sepsis, starting from noting the recent data about maternal sepsis frequency, mortality, and human suffering, unfortunately, still on the rise. Prevention and management of maternal infections are complex challenges and require a comprehensive response, from addressing individual level risk factors such as anemia, for example, to changes in care practices to improve monitoring of women during hospital stay and appropriate use of preventive measures, including antibiotic prophylaxis, which has been emphasized several times. The health systems and the lack of an enabling environment have been highlighted as important issues, and these are at the core of the WHO work as well. Overcrowding, limited access to water and sanitation, access to safe and appropriate antimicrobials, substandard infection prevention and control measures can reduce the ability of healthcare providers to manage maternal infections and sepsis. Speakers also highlighted the need to fill the global shortage of health workers, including midwives, so that women get the life-saving care they need during and after pregnancy. Strengthening community health care and universal health coverage has been identified as a high priority as well, so we can more closely meet the needs of women and enable equitable access to critical services during and after pregnancy for timely identification of risk factors and/or infections that can evolve to sepsis. Strong engagement of communities in the planning, delivery, and evaluation of the health service that serve them, and this applies very positively to pregnant women and their families, have been also highlighted. Women and their families can play a very active role in identifying signs and symptoms of sepsis. Therefore, efforts to address sepsis must engage and integrate communities as a proactive, systematic activity that creates opportunities for their education and involvement and builds relationships with healthcare professionals. Speakers mentioned several times weaker and less integrated health systems in low middle income countries that present significant gaps in the ability to prevent, diagnose, and manage maternal sepsis. Thus, our efforts in the fight to sepsis should be urgently concentrated on adapted interventions for capacity building in these countries. WHO is supporting solutions to these issues and countries and stakeholders' improvement efforts in the area of sepsis, and in particular maternal sepsis. Several examples have been provided already during this session. I just would like to draw your attention on recent resources we made available on infection prevention and control and hand hygiene measures during the pathways of women and their babies from the prenatal to the postnatal period. And every year, as you may know, on 5th of May, we celebrate World Hand Hygiene Day. This year, we call on civil society and other partner organizations, including yours, to accelerate progress at achieving effective hand hygiene and IPC practices at the point of care. You can find more information on our website, and I really invite you all to take part in these global activities. I also would like to point out that 5th of May is also the International Day of the Midwife, and the coincidence of the 2 days is very timely to establish connections between the two areas of work. Finally, also many thanks to the WHO Department of Sexual and Reproductive Health and Research, which includes the Human Reproduction Program, for contributing to the organization of this session. And last but not least, really many thanks to the Global Sepsis Alliance for organizing this Congress and their commitment to keep maternal sepsis high on the agenda. Many thanks to you all for participating in the section and for continuing strongly your work on sepsis, especially maternal sepsis. Thank you.
Many thanks, Benedetta. Many thanks to all our panelists and, of course, to our audience. I think that this was very, very good session. There's still few additional sessions for the day on the Congress. You are very much invited to listen to them. And with that, I would like to say goodbye to everybody.